cool welcome from Cape Town because we just had a most terrible rain shower here. You'll see Samantha Budrum at the top there. She's from Stellenbosch, which is just around the corner, and she also would have seen us. Now, the reason why we have to wear masks over here, we've had a sudden outbreak, Ash, of, here's Ash over here. She's taken over from Steve, who's laid low. So I'm running it tonight with the help of Dr. Samantha Budrum. Or shall we rephrase that? Dr. Samantha Budrum is running it tonight with the help of Ash. So you'd also see at the bottom over there is we have Cynthia of Mindray, and she's going to be saying a few words after Samantha's presentation. Just a few words about Samantha. Samantha is in fact a subspecialist in maternal fetal medicine, and she's at the Tygerberg Hospital and Stellenbosch University. And if you have a look at the main picture over there, Samantha, is that the swimming pool at the Tygerberg Hospital?
Yes, at the medical campus.
Oh, the medical campus. And I suppose you, having spent some time there, have spent many a happy hour in the swimming pool, yes?
No, not really.
Not really. Okay. Anyway, so you got your degree at Wits, and then you trained as an obstetrician and gynecologist in University of KwaZulu-Natal. And then you got an MPhil in maternal fetal medicine from Stellenbosch University. And the important thing is that you are the secretary of the South African Society of Ultrasound and Obstetrics and Gynecology, who's just had their major meeting, and also executive member of the Society of Obstetrics Medicine of South Africa. So, ladies and gentlemen, we couldn't have had a better qualified person to come and speak about the first trimester ultrasound. I'm hoping that you do leave us a few minutes at the end, Samantha, so we can ask questions. Would you mind?
Yeah, I'm hoping to actually leave quite a few minutes at the end because I'm actually hoping to get some very good feedback and questions from the audience.
Okay, we've got some wonderful questions already lined up. And then finally, just before we knock off, you don't have any load shedding issues there because, you know, nowadays we have load shedding issues and we have to work around these. Are you okay with load shedding? You're not going to be struck down, are you?
No, I should be fine.
Okay, thanks very much. Ash, are we okay here with load shedding?
We are. We're all good.
No problems over here this side?
No problems.
You'll remember a few weeks ago, Samantha, we had Zoe Momberg, and she was giving a presentation, and right at the beginning we had load shedding, and the whole thing started 30 minutes late because we just couldn't log on. Do you remember that, Ash? Yeah. And everybody's generators started up and everybody was going with their generators. I felt a bit left out, so I went and started my lawnmower. So people thought I had a generator outside my old Briggs and Stratton. I don't want to be the only guy on the road that doesn't have a bloody generator. I mean, how humiliating. Anyway, so no load shedding without any further waste of time. Samantha Budrum, subspecialist in maternal fetal medicine, the first trimester ultrasound. We look forward to it. Thank you very much indeed.
Good. Thank you very much for that very kind words. And I must say it's a pleasure being on this platform and speaking to you about on this topic this evening. So, and a very good evening to our audience. I'm glad to see that there's actually so many participants who are interested in hearing about first trimester ultrasound. So I'm actually going to get going because I'm going to actually start off my first slide telling you that's an extensive topic and I'm not going to go through everything. So, and I also don't want information overload on your side. So I've actually decided that I'm going to focus on predominantly diagnosis in first trimester ultrasound, and then touch on two topics on the screening aspect of first trimester ultrasound, and that is structural anomalies and screening for aneuploidy. Obviously, there's much more to screening in the first trimester, though I'm not going to go into detail in that. Perhaps it's for another session. But I could maybe say a few words on it. So as you can see, our goals predominantly when we look at first trimester ultrasound is diagnosing that we have a viable intrauterine pregnancy, and very importantly, working out an expected date of delivery or the gestational age. And I cannot emphasize enough, when we do diagnose a multiple pregnancy, one of the key things we want to know is what is the chorionicity, because our entire management of such a pregnancy hinges on knowing the chorionicity. And then, as you know, as ultrasound has developed and the technology has improved many-fold, we are now able to see much more than we could previously in the first trimester. And we're starting to diagnose more in terms of anomalies in the first trimester. So there are certain things that if you are going to do a first trimester ultrasound that you should know, that you should be looking out for in order to diagnose these. And very importantly, screening, which has now become widespread and should be offered to every pregnant woman. So starting off right at the beginning, and I said that if you choose to do first trimester ultrasound, so can you just choose to do first trimester ultrasound? Well, the answer is pretty much no. There are some prerequisites when you have actually decided that you want to do it. So you should at least have completed a training course in the use of diagnostic ultrasound, and you should know the safety issues related to it. As you are probably well aware that the first trimester is an extremely sensitive period for the fetus and the entire embryogenesis. So therefore, using any sort of, whether it be drug therapy, whether it be imaging, you need to obviously know what are the safety issues regarding the use of that particular technology or therapy. So you should also participate in continuing medical education activities, and that's extremely important. And that is because we, as I mentioned previously, that there is been an extreme move towards much of care moving towards first trimester diagnosis and screening, and things are changing rapidly. So what we knew 10 years ago is very much different from what we know now in terms of first trimester screening and diagnosis. And obviously, when you are undertaking any examination or any test, you should know what are you going to do if you find something abnormal or suspect something abnormal. So you should always have the care pathways in place for referral of patients with such findings, and very importantly, have quality assurance programs in place. So just a word of the safety of use of ultrasound in the first trimester. You have to always bear in mind that we consider ultrasound to be safe in pregnancy, but it remains a form of mechanical energy. So although largely it is safe in the first trimester, when extremely sensitive period for the fetus, we really consider the B mode or grayscale Doppler probably safe, but high energy levels with use of Doppler in the first trimester. So these are associated with possible risk to the fetus. So when we do first trimester ultrasound, we probably spend as less time as possible using Doppler and probably more time on B mode. And then, as you can see, I have indicated on the image to the right of the screen, there is something called the thermal index, and that is represented by the TI. So it is a predictor of the maximum temperature increase in soft tissue or bone. So in the first trimester, we want to keep that as low as is possible. And in general, in obstetrics, we aim for less than 1. But if you are using the first trimester, please make sure that you're at least sitting at less than 0.7 on your thermal index.
Samantha, can I ask you a question?
Yes.
On this very platform a couple of years ago, we had a person that showed us color Doppler of very early fetuses, and he was showing off, this chap was showing off the color Doppler to the parents. Would you say that's not a good idea? And secondly, Many of our people that I've logged on, I've had a look at who's on here. They might not know what B mode low is. Could you just expand on B mode low, please?
Okay, so basically, first of all, I want to just say about showing off to parents. I think you've got to realize that it is a clinical examination that you're undertaking. And yes, it's good enough to show the fetus to the parents. But again, once you're using Doppler, you've got this potential harm, and that risk of harm increases. So I would definitely shy away from using Doppler for when it is not necessary. Definitely not for showing off to patients. We do use the Doppler in the presence of first trimester scanning, and that is probably to achieve certain endpoints, and those endpoints obviously are involved in screening, and I will come to them as we go along in the lecture, but definitely not used for just willy-nilly things or showing off to parents. The B mode low is generally the kind of setting that we have, in which basically we are predominantly just visualizing the fetus on the grayscale and avoiding any sort of, again, color interrogation of the fetus. And you can, I mean, there are people who actually help you to set up your machine, and you can have these set as presets for first trimester scanning, so that you avoid these so-called harms that may potentially occur to the fetus.
Thank you.
Okay, so very important in the first trimester is to know what to look for and when to look for it. And that's it. So the first trimester, we may think it's only 12 weeks, and we know that nowadays, and people being obviously more accessible healthcare and wanting to know from early as possible what is going on in the pregnancy, that we are using ultrasound more and more earlier in the pregnancy. So actually the first trimester is actually divided up into the early first trimester versus the late first trimester. And the first 4 to 10 weeks is considered to be the early first trimester. And what you actually want to achieve in the early first trimester. Early first trimester, if it's really early, and we're talking about here where you're not even seeing the fetal pole, we're talking about really after the patient presenting for the first time, roughly about 4 to 5 weeks. When we're talking about 4 to 5 weeks, you probably may have difficulty seeing transabdominally, but on a transvaginal scan, you're probably going to be able to see what we call the double decidual sac sign in an intrauterine pregnancy, and you are going to be able to see the gestational sac, not yet a fetal pole. And I'm not yet sure if you can see my marker, but if you are, you'll be able to see that there is a yolk sac seen there. So this is also referred to as the donut sign. So really what you're wanting to see is a replica of the donut, usually implanted in the upper segment of the uterus and usually eccentric. So that's roughly what you want to see very early on when you're first diagnosing the intrauterine pregnancy. You can then, obviously, in the absence of the fetal pole, measure the gestational sac diameter. And what we suggest when you're measuring this is that you use the 3 orthogonal planes in measuring and you use the mean of the 3 planes. We do not use this for dating of the pregnancy, but you may actually use this just to get an idea of how far you are in a possible pregnancy. The dating will come about when I speak a little bit later about the optimal window in which to date a pregnancy. At about 5 weeks, we are then able to clearly see a yolk sac. And as you can see in this particular image, a yolk sac that is clearly visible inside of the gestational sac. And about going on to 6 weeks, we'll be able to actually see a fetal pole present. And you see a fetal pole on the right image, and again, the yolk sac that is still pretty much present. So this is what you expect to see in a normal pregnancy at about 6 weeks gestation. If you have any concerns that the pregnancy might not be intrauterine, then obviously your transvaginal scan is definitely the way to go, and you will follow the endocervical canal into the uterine cavity. Okay, very important, and probably the most important in multiple pregnancies is this is actually the stage where it's easiest to make the diagnosis of what the chorionicity is. And as I mentioned before, all our management hinges on this. Quite clear from the image to your left that it is dichorionic. You have a thick chorion in between the two gestational sacs, as opposed to the image on the right, where we do not have the thick chorion intervening, and then we have two yolk sac presence, which really is suggestive of a monochorionic twin pregnancy. So probably extremely easy to make the diagnosis. And really, if you are making the diagnosis at this gestation, I would urge you to print an image of this, because it really takes away any doubt later on in the pregnancy when we have to make difficult decisions regarding the chorionicity of the pregnancy. So when we get to about 7 weeks, we are seeing the actual fetus with the fetal pole. You may still see evidence of the yolk sac, and just round about the fetus there, that is the amnion. So seeing the amnion separate from the chorion is not unusual. Generally at about 12 to 14 weeks, thereabouts, does the amnion completely fuse with the chorion. So really seeing the amnion rupture is a normal finding, and you should not be perturbed by actually finding this really. So when we look at the late first trimester is when really the dating comes in. So the late first trimester is considered anything from 10 weeks to about 13 weeks and 6 days. So we are very firm followers of the International Society of Ultrasound in Obstetrics and Gynecology, and in keeping with their guidelines, that every woman should be offered an early ultrasound scan. And the ideal time to perform the scan would be between a crown rump length of 32 millimeters to 84 millimeters. And this would be the time that we would expect you to measure the crown rump length and to establish accurate gestational age. And this is obviously an ongoing problem for us who work in the public sector, where obviously we don't have many women who actually have the scan at this gestational age. Very important, and is that when you are measuring the crown rump length, there are certain criteria that should be met. It does not, we see very often patients refer to us with images of fetuses lying in every other position except that in which the crown rump length should be measured. And it is critically important that if you're going to do it, you do it properly, because our dating and hence the management of the rest of the pregnancy depends on this. So it should be a midline sagittal section of the fetus. The fetus the image should be large enough so that it occupies as much of the screen as possible, because you increase your margin of error when you measure things that are really small and unclear. The fetus must be in a neutral position, so you should avoid doing a crown rump length if you find that the neck is hyperextended or the neck is flexed. And in the images to follow, I will show that it does make a big difference in terms of dating when you do measure that. You must be able to clearly define where the crown is and where the rump is, and do not include any other structures, example, the yolk sac, in your measurement. And generally, we say that you should know that your fetus is not too flexed if you can see a pocket of fluid between the chin and the chest. So the amniotic fluid just beneath the chin so that you know your fetus is not too flexed. And then you measure the maximum straight line distance from the crown all the way to the rump of the fetus. Generally, you should be able to measure at least 3 measurements and take the mean of it. If all 3 of them have been with the fetus in a good position, then really the mean should be taken. How do we date them? So we generally, sorry, I will come to that again. So common errors. So you can see the image to the left here where the fetus is hyperflexed. Okay, so you can't even see a pocket of fluid between the chin and the chest, and then you obviously are going to undermeasure the actual crown rump length. And that to the image to the right is where we have a fetus that is hyperextended. And if the fetus is hyperextended, quite obviously, then you are going to land up with an overestimation of the crown rump length. And in this particular image, the one on the left, as you can see that we only just using probably about 20% of the screen. So the image is too small. And if it's too small, we don't actually end up properly finding where the actual crown and actual rump is, and our margin of error increases. So avoid doing that. Make sure you make full use of, as we always say, depth, focus, zoom, and that is the order in which you should optimize your image. You increase the depth maximally, you put your focus to the area of interest, and then you zoom it if you need it to be further enlarged. So always remember that when you are optimizing your images. The image to the right, quite obviously, we cannot really distinguish where the crown of this fetus is. Neither is it in a mid-sagittal section, so this should be avoided at all costs. Do not measure a crown rump length if you are actually dealing with that. Okay, so the expected date of delivery is extremely important. You should ensure that the pregnancy that you are dating with this crown rump length is actually a spontaneously conceived pregnancy, that the last menstrual period is certain. And obviously you would have gone through the tick box of things of when it comes down to certainty, and that is, has the patient make sure that it's been a regular period for patient gets it every month, it's been normal in terms of duration and flow. The patient has not been on any sort of contraceptive or breastfeeding in that last time. And then you can also ask questions around the certainty of it. And then usually how we would choose to date is if the LMP is indeed certain, then and the gestational age falls within 5 to 7 days of the crown rump length, then we would date by the last menstrual period. If it is outside of that window, then we would date by the crown rump length. And extremely important, because we do find quite often that people do subsequent ultrasounds, and with every ultrasound that they do following that, they tend to adjust the expected date of delivery. Once you have dated a pregnancy accurately, you need to clearly document it, and this gestational age or expected date of delivery should not change for the duration of the pregnancy.
Samantha, can I just ask, why do people do that? There's 2 common problems. The one is women are fixated on their PathCare beta HCG level, which translates to so many weeks, and you can't get that out of their head. And the second thing is this business about changing the EDD. You never know where you are, and they don't understand that the first EDD in the late first trimester is cast in stone. So I suppose those are 2 things that we have to persuade the patients are absolutely unchangeable.
Yes, that's very correct. I think it has a lot to do with counseling and education when you do that first scan, because it's always the tendency of the patient when you tell them, well, you know, what was the expected delivery? They said, well, I was told this, but I've had the scan last week and it said this. So I think I'm actually this far pregnant. So I think it's very important to just spend that extra minute or 2 to tell the patient that this is your date of delivery and it will not change for the duration of this pregnancy. I think that's extremely important. Okay, so what about if we're dealing with multiple pregnancies at 10 to 14 weeks? So what do we want there? We want to date the pregnancy. We want to label the fetuses. And I've mentioned previously, and I know I keep harping on about it because it is a problem. We want to determine the chorionicity and the amnionicity of the pregnancy. So we do obviously stick to the same strict protocols. And again, depending if you are dating by a crown rump length and not the last menstrual period, then always date by the crown rump length of the larger or largest fetus. And that is because it protects you against and missing out on a fetus that is potentially growth restricted later on in the pregnancy. So if you date by the larger one, you are more likely to pick up the fetus that is having a growth aberration later on than if you measure by the small one, and rest assured that this pregnancy is all going fine when it's not. Labeling, that's another extremely important, and we keep on saying it, is that there should be labeling of the fetuses, and that is usually done at the first ultrasound. And you can choose the way you label the fetuses. So it can be in the way in which they lie. So there can be a top-down configuration with fetus A, for example, lying closer to the internal os of the cervix and the other one lying above it. The fetuses could be in a left-right configuration, so maternal left and maternal right, and you choose which one you choose as A or B. You can actually, if they are separate placentas, then say, okay, twin A has the anterior placenta versus twin B has a posterior placenta, or where the cord inserts on the placenta. And the reason for this is that on subsequent ultrasounds, we actually use the labeling of the fetuses to follow the growth trajectory of the fetus. And if we do not know who's who, then we can actually end up mixing the growth, and following the growth trajectory becomes a problem. So it's extremely important that we label the fetuses and we maintain that labeling for the rest of the pregnancy. Obviously, the difficulty comes in monoamniotic twin pregnancies. That is a problem, because those fetuses obviously can actually go in all parts of the amniotic cavity. But in those cases, we do try hard to find, is there some sort of distinguishing feature? Example, it may be that one fetus has an echogenic focus in the fetal heart and the other doesn't. So we try our best. Sometimes it's just not possible at all to actually establish in monoamniotic twin pregnancies which fetus we have been following up growth on. So that is a problem, and we accept that that is one of the shortcomings, or one of the shortcomings of actually ultrasound and following growth in monoamniotic twin pregnancies. So at 10 to 14 weeks, we now move on to what we, again, probably one of our next chances, if you have not yet worked out your chorionicity, and this is typically where, if you have a single placental mass, you are going to look for the insertion of the membrane into the placenta. And typically in a dichorionic twin pregnancy, what we will see is the so-called lambda sign. With the lambda sign, it's a nice thick intertwin membrane because we have 2 chorions and 2 amnions, and we see the chorion actually entering into the section where the membrane inserts into the cord. Membrane inserts into the placenta. So that is the lambda sign. And if we do see a lambda sign, it is a dichorionic twin pregnancy, as opposed to the image on the right, where we have a thin intertwin membrane. We examine the insertion of the membrane into the placenta, and we do not see the classical lambda sign. So there's absence of the lambda sign, or some people refer to it as the T sign in a monochorionic twin. Then we are happy to label this as such. So remember, this is first trimester is the optimal time of working out your chorionicity. We lose a lot of these features as we move into the second trimester, and almost impossible to see in the third trimester. So again, important if you do see them, label, diagnose your type of twin, and if possible, print an image and attach it to your report.
Samantha,
Yes.
can I just ask a question about chorionicity? The average person that's listening over here is not feto-maternal. It's just a jobbing gynecologist or a chap in a rural area. And there's over 150 of them. So you've got a wonderful turnout today. Anyway, so if you find a monochorionic twins, can you manage them yourself, or should they be referred to a higher setting? What is your opinion on that?
So I can tell you, well, of all the twin pregnancies, obviously the monochorionic is the highest risk. And if you are not first in the management of them, or in surveillance of monochorionic twins for their unique complications, which some of you may have heard about, twin-to-twin transfusion syndrome, trap sequence, selective growth restriction. If you are not able to do all Dopplers and follow up growth and look out for these complications, then they are not safe in your hands. I would actually recommend referring monochorionic twins to a subspecialist who can look out for these.
Thank you. Thank you.
So what have we looked at so far? We have actually looked at the location. We have worked out the number of fetuses. Is the pregnancy actually viable? We've looked at gestational age, and in multiple pregnancy, we have looked at looking at the chorionicity. So we're going to move a little bit now on, and we're going to say that if you are doing the scan in this period of these 10 to 14 weeks, what else should you be looking out for? So if you are doing the scan, you're expected to screen for certain structural anomalies, okay? And again, we move back to the guidelines. What do the guidelines say? So if you look at this guideline, it says, what should you be able to look at in the first trimester in with fair amount of confidence? And in the head, and I will probably show you some images of this as we go along, the head, you can almost see quite a few things that you will be able to look out for. And I'm not going to actually go in detail here, because I'm going to show you some images of what I expect the person to see who's doing the scan. And this is really not even at the level of a fetal medicine specialist. This is at the level of a generalist who is choosing to perform a first trimester ultrasound.
Okay, so can I just ask a question? The generalist person, we have a home industry, and you probably be aware of people that set themselves up in their garages doing scanning, and they've got very interesting names that I don't have to mention because you'd also be aware of them. What is your opinion on those people that do take money from patients, give an opinion, and they refer them on with a sort of a quasi-obstetrical medical report?
Yes. So
are there any use at all or not?
Yeah, so I think I'd be very wary of that. I think if you are going to be doing ultrasound, and you will see in the next couple of slides coming up, you should have underwent the training. You should undergo the courses that are available, and you should be certified and accredited to do what you should be doing. And that should be made known to the patient. So at the beginning of the scan, you should tell the patient what your abilities and your accreditations are and what your limitations of the scans are. And definitely when it comes down to first trimester ultrasound, I should tell you that really you should not be doing first trimester ultrasound unless you've been through the training and have gotten the accreditation to do such.
Right.
So definitely hands off. If you otherwise, let the patient know that you are not trained or not accredited, and then you do not move further with that particular ultrasound. Okay, so really, what are the things that we can actually diagnose with 100% accuracy in the first trimester? That it's in the green box. acrania, anencephaly, ectopia cordis, that's where the heart sits outside of the thoracic cavity, and an encephalocele. So those are the things that we should definitely be able to see and scan. And then there are things that really we cannot diagnose in the first trimester, and that is because those organs have not reached their full development for us to see and visualize those things in the first trimester. So if you are doing a scan, and we have had patients who've had first trimester scans who come in with acrania at a later stage, and that is because it's done in the hands of the wrong people. Okay, so the fetal head, what are we expected to see? So this is about fetus around about 12 weeks. We expect to see that the skull is indeed complete and that there is a skull present, that there is a midline, the falx, that runs from the anterior aspect to the posterior aspect of the skull, and the choroid plexus, which are the two very echogenic structures that really appear as a butterfly-shaped structure, completely filling the ventricles in the first trimester. So it's a typical transverse section through the fetal head at about 12 weeks, and what you should be seeing. The chest, you should have symmetrical lung fields. You should have regular cardiac pulsations. There should be no obvious effusions and no masses. So and there should be no cystic structures. If you're seeing a cystic structure in the chest cavity, then obviously that patient needs to be referred out. We're concerned about many things, including diaphragmatic hernias, which can be diagnosed in the first trimester. You also want to make sure at this stage the stomach bubble and the heart are on the same side, and it is indeed the left-hand side of the fetus. So here is a little bit movement down towards in the abdomen. So the two sort of fluid-filled structures you will only see through the abdomen would be, one is the stomach bubble and the other is the bladder. Should be not seeing any other fluid-filled structures in the abdomen pelvic area of the fetus. So we do see a stomach bubble. If you do not see a stomach bubble, then you can either scan the rest of the fetus and come back to look for the stomach bubble, or you can ask the patient to have a walk around and come back after a little while to see that there is actually a stomach bubble present. That's two things we want to see, the stomach bubble and the bladder. So the stomach bubble, you can see clearly in this image. You want to be able to see the cord insertion into the abdominal wall, and you want to make sure that's intact. We do have, as you know, physiological herniation of bowel into the at the level of the umbilical cord, but generally by about 12 weeks, we expect that bowel to return into the abdominal cavity and for you to see basically a normal cord insertion with no bowel present in that particular image. So I'm going to talk about the fetal bladder. So I told you the two fluid-filled structures. One is the stomach, the other is the bladder. A bladder should always be visible. Again, if you do not see the bladder, the patient can walk around. You can scan other things and come back to it in a little while and make sure that you do actually see the bladder present. And I've written a measurement here, not because that I expect every person who is scanning to measure the bladder, but there are cases in which what we call megacystis. We have a large bladder, and if a bladder catches your eye, it probably means that you're worried that this bladder is much bigger than it's supposed to be. Yeah, then you may measure it, and anything above 7 millimeters would be considered to be abnormal. I'm not going to go into details of why, but if you ask me that question somewhere along the line, I can answer it for you. The other things that you can also look at, but may really not necessarily be as important as what we've mentioned so far, is you can look at the spine. Very difficult unless you have a large lesion to make a diagnosis of a spina bifida. You should make sure that there are 2 hands and there are 2 feet and there are 3 segments in each limb. That you can eyeball the liquor volume and make sure that there's sufficient liquor. that the umbilical cord is present, and we do routinely check that there are 2 umbilical arteries. And how we do that is by, again, using the color flow alongside the bladder to visualize the 2 umbilical arteries. And the placental location, I think that's particularly important in a topic that I'm not going to cover now, but it's in a very early screening for placenta accreta spectrum disorder. But as I said, that's not going to be covered in this talk. Remember that you are in the first trimester, so there are other things that you can look at. You can look at the uterine wall and make sure that there, example, aren't any myomas present. You can look at the adnexy and the cervix, particularly important, the cervix in patients who've had a history of previous either preterm deliveries or mid-trimester miscarriages in which you suspect or working the patient up for possibly a cerclage.
Samantha?
Yes.
Sorry, Samantha, can you, yeah, that's right. Am I wrong to believe that every woman should have her cervix measured in the first trimester? Would you say is that a good practice?
Okay, so we do not routinely measure the cervix in the first trimester, unless obviously we have a specific history, but at mid-trimester, it is recommended that every woman should have the cervix. So at the time of your detail scan, the 20-week scan, it is recommended that you should look at the cervix, and that would be, again, if you find a short cervix in an asymptomatic patient or without a history, then there is still place, for example, progesterone therapy, and those with a history, either progesterone or cerclage. So yes, definitely at the time of the mid-trimester, but not necessarily at the time of the first trimester. We do look at the cervix transabdominally, obviously, in the first trimester, because it is part of us working out that it is intrauterine, but we do not routinely measure the cervical length in the first trimester.
Don't you think it's a good idea? Because if you do find a short cervix or a dilating cervix, something can be done at the end of the first trimester instead of losing it perhaps as a mid-trimester miscarriage.
So basically the feeling is that definitely in the patients that are at risk, finding a short cervix, you're probably not going to find it from thinking of the pathophysiology of cervical incompetence in the patient where they do not have a history and have had previous perhaps term deliveries. You're probably not going to find that short cervix at the time of your first trimester scan.
Okay, thank you.
Okay, so I'm going to move on for the next few minutes on what do we do in terms of screening. And I want to say screening for Down syndrome. Yes, we do screen for other aneuploidies, but the first trimester scan is really geared towards screening for Down syndrome. And the reason why is because obviously it's an early screen. It's the one with that's associated with intellectual disability. Usually when it comes down to 13 and 18, we see hard markers, big structural abnormalities, so much easier to diagnose. Many of those 13 and 18s don't go on from land up in miscarriages, whereas 21 is a little bit different. So it's predominantly geared to 21, yes, but we definitely can screen for the others as well. So nuchal translucency, again, primarily a screen for Down syndrome. It is an examination. It is a patient's choice. So you need to counsel the patient and get informed consent. So a patient has to tell you that I want to be screened for Down syndrome. Not every patient wants to know that information. So before you even decide to do a nuchal translucency scan, you need to tell them what you're doing, what the purpose of it is doing, what does a positive result mean. In our setting, we let them watch a little video, a video of about 10 minutes long, which explains what Down syndrome is and the entire process of it. And at the end of that, the patient tells us, yes, I want an ultrasound, but I do not want to know anything about Down syndrome, in which case we will perform the first trimester scan, but we do not calculate risk for any of the aneuploidies. requirements, and I spoke a little bit about this earlier. So the Fetal Medicine Foundation has a training in place, and they also are able to issue certificates of competence in nuchal translucency. There is a theoretical internet-based course, which you will go through with the 11 to 13-week scan. You are then submit images to the Fetal Medicine Foundation, and if they're found to be suitable and you pass a test that is also done online, you are then accredited and you are given a license, which is valid for 1 year, including the software in which we use to risk calculate. Every year, you are then expected to renew that license by going through the course, submitting your images and doing the test again. And that works out for NT, nasal bone, and the other two soft markers that I'm also going to be talking about. So if you want to know if you're accredited or you want to find an accredited person, you go onto the Fetal Medicine Foundation, and there's a page which links you to each country and the accredited sonographers in that particular country for carrying out these examinations. So the NT measurement, again, it's done between 45 to 84. Why do we choose 11? Because 11 weeks is probably the time at which we can do an invasive test if needed. That's being a chorionic villus sampling. Earlier than that, we would not do it. It's associated with transverse limb defects. And not beyond 14, because it's better to diagnose something in the first trimester and offer a termination in the first trimester rather than now going on to a second trimester diagnosis. Again, completely mid-sagittal section of the fetus. Fetus must be neutral. This time around, you magnify your image to only include the thorax and the head of the fetus. And then the fetus must be away from the amnion. So if it's otherwise, you can be quite sure to measure the NT, thinking that that is actually the NT when actually it is the amnion of the fetus. So the fetus should be away from this amnion. So you turn down the gain or make your image pretty much darker. So that usually is on your 2D dial so that you can clearly define the lines. And the calipers are actually placed on from inner to inner at the maximum distance of the nuchal. And then we take more than one reading, and we generally take the largest distance to be the correct NT. But obviously you have to meet all these criteria before you decide to perform the actual NT examination. Just to remind you that the NT is gestational age dependent. So for a particular crown rump length, there is the upper and lower limits or the 95th centile measurements for the particular NT. So we don't use a specific measurement. We rather you put that into our software, which will then risk calculate it together with the maternal age and other factors that are included in the risk categorization. So the second thing that we look for, and it can actually be assessed on the exact same image as you do your nuchal translucency, is the nasal bone. And in the first trimester, what we are looking for is we're looking for the equal to sign, and that there is the equal to sign. Why do you want to see the equal to sign? Because actually the upper point is actually the skin, and you may actually take the skin for being the nasal bone and actually report a present nasal bone when it is indeed actually absent. So you should see these two echogenic lines or the equal to sign, and that actually tells you that there is a nasal bone and it is present. We do not measure in the first trimester. We either report as absent or present. So what are the additional ones? Yes, you can refine your risk for Down syndrome even further. This is also training and certification that is offered by the Fetal Medicine Foundation. That is your ductus venosus Doppler. which is reported as being absent A wave or reversed A wave. So at the top of your screen, you will see a normal waveform of a ductus venosus Doppler, and in the bottom of the screen, you will see the so-called reversed A wave. So that is reported as absent or reversed A wave when we screen for Down syndrome in the first trimester, which is more associated with Down syndrome. And the fourth marker that we use is tricuspid regurgitation, which is again another marker associated with Down syndrome. And here you will see on your right of your screen a normal Doppler of the over the tricuspid valve, and the one that's denoting tricuspid regurgitation, which during asystole is a wave form in the opposite direction. Again, this is also certified by the Fetal Medicine Foundation. So where does this put you? Just to put you into the whole picture of where we are. If you screen only by maternal age, your detection rate will be about 30%. If you add nasal bone, then you're sitting at about 60 to 70%, maternal age and nuchal translucency 70 to 80. And then if you add serum biochemistry, you go up to about 90%. And then if you look at the last one, you can go maternal age, NT, nasal bone, and biochemistry, which takes you up to about 95%. Obviously, the best would be NIPT. If you have that available, then NIPT can take you beyond 99%. And then the screening falls away from the first trimester ultrasound. We will just do a structural anomaly scan in the first trimester.
Samantha, sorry, take home message. I just quickly want to, we've got a whole lot of questions. I just want to skim through them so we don't miss them. Duduzile says, when should we check for fetal heartbeat with the M mode? Can we use color Doppler if we still can't pick it up? Yes or no?
So generally, there's no need to use color Doppler. You are going to pick up the pulsation of the fetal heart. It's fair enough to use M mode, but I must say most of the times you are going to just pick up by looking at the image. So generally about 5, I would say if you're doing the transabdominal scan between 5 and 6 weeks, you should start already seeing the flicker of the fetal heart. You can use the M-mode Doppler over it if you want to. It's pretty safe, but just looking at the screen should be sufficient.
Thank you. Leon Nell says, the skull sometimes looks edematous, affecting measurements. So would the femur length be more accurate if it happens?
So definitely not in the first trimester. We definitely won't use the femur length in the first trimester. The measurements are not accurate. So I would say stay away from it. If you're seeing edema of the skull, I would consider actually referring that patient because there's already something that's concerning on that scan. Okay.
Ilona Shihama says, what would be the best intervention? Now, you're going to put on your hat as a fetal medicine consultant. What is the best intervention if a short cervix is incidentally found in the first trimester in a patient with no previous history of miscarriage or no history of any cervical procedures? What would you do?
What would I do? Okay, so I suppose the one question I would have liked to ask is how short is this short cervix?
Let's say for argument's sake, it's 15 millimeters.
Yeah, so for me, I think I would use 15 millimeters as a kind of cutoff in a patient who does not have a history. What I am saying is not evidence-based. This is my personal opinion because, as I said, I don't measure them in the first trimester. But I think if the cervix is less than 15 millimeters, and I've done a scan to find that I'm happy with my first trimester scan, I may actually consider offering that patient either the option right now of a cerclage versus progesterone to start at probably at about 16 weeks. Yeah.
Okay, thank you very much. Now you are the secretary of SASUOG, are you not?
Yes, I am.
Does SASUOG have guidelines for informed consent, verbal or written, This is a question from Siva Mudli. Siva?
Yes, Dr. Medley. SASOG does have guidelines. I must apologize that in the last week, our website was hacked into and has gone down. But yes, they do have guidelines that are available. And I actually can actually send them to you because I actually do have hard copies. But yes, there are guidelines.
Okay. And the last, in the last 5 minutes, we always have a question from Habib M. Habib of Nairobi. You mentioned all women deserve a first trimester scan, and that's the feeling of SASWOG, is it?
Definitely, yes.
Yes. Now, this is his question. We heard from Zoe Momberg that the NICE guidelines say that tertiary level scans for all women on a regular basis are unnecessary. What do your guidelines say about that?
Okay, so I think I must say it's a guideline, and I probably, Zoe, but yes, and people have reasons for saying what they do. So what I've told you is that all women should have a first trimester scan is not actually what's practiced. It depends on your resources. So when a guideline is out there, it tells you what the ideal may be, but you may sit in a situation where your resource cannot meet that. So if you are, we all say that all women should have at least one high quality scan in their pregnancy, and preferably one scan that particular scan can also be used as the dating scan. So I think if you're going to say what is in an extremely poor setting, if you are only able to offer a patient one scan, I would personally say that scan would have to be the detailed scan at between 18 and 22 weeks, because we could still date the pregnancy, we can still screen for aneuploidy, and we basically can perform a full structural anomaly scan.
All right, we can debate that. Maybe we can get you back, Samantha, and we can discuss that issue. Anonymous attendee says, better doing NIPT than going through NBA wave. Does that make sense to you? I'm afraid that's lost me.
Better doing NIPT than going through?
NBA wave. Have you got that question in front of you? No.
No.
Okay. Well, let's move on to Stavros Stavridis. We've answered that question. The FMF certificate of competence needs to be renewed annually. That's what you said. At what cost? What does it cost to review it annually, or is it free?
It's free, completely
okay,
free.
Good. Okay. Anonymous says, what is the guideline? This is a nice one. What is the guidelines for cervical length monitoring in twin gestations? Do they exist or not?
Okay, so very contentious issue, as you do know, and I'm talking about. I'm assuming they're talking about not late in pregnancy, but the mid gestation.
Yeah.
I think we've been sitting between a rock and a hard place between progesterone and cerclage in multiple pregnancies, and I think really for me personally, I think if a patient has risk factors and you are finding a short cervix at the 20-week scan, there is room for progesterone. So I would definitely offer
I think the SAMF guidelines say that you can use progesterone. And these are the very latest updated guidelines. I know because I wrote them. Now, the final thing is this. Can you give us a take-home message? We don't want to keep you any longer. And you've got two more minutes, Samantha. It's been a wonderful talk, but we've got to give Cynthia a message as well.
Okay, I'm taking 1 minute so she can have her other minutes back. So take-home message: we should offer all pregnant women this. Obviously, as I said, it's if it's within your resources. Confirm that the intrauterine pregnancy and that it is actually viable. Accurately dating of pregnancy. Chorionicity in multiple pregnancies, counsel, anatomical survey, any issues, refer.
Thank you very much indeed. It's been wonderful. Sorry, practice is the best of all instructors. Did you say Pietra Steyn? Is that Pietra Steyn? No, hang on.
Oh, no.
I thought it was Pietra Steyn, sorry.
Oh.
Do you know Pietra Steyn? Anyway, so the first thank you goes to Mind Ray, who's our sponsor, And Mahendra, thank you very much. Cynthia's going to say something. The most important thank you, of course, is to our presenter, Dr. Samantha Budham. And then a final thank you to Ash and Karen, who set this whole thing up and will be, God willing, carrying on every week with us. Remember, next week we have challenges in managing infectious diseases during pregnancy and the neonate. So that'll be another one. I'm hoping we get as many as we got for you, Samantha. Seldom do we get 200 people, but you certainly knocked it off the block. And our presenter next week is Dr. Despina Demopoulos. Dr. Despina Demopoulos. So now, thanks once again. Cynthia, it's over to you. You're the marketing specialist, and you're going to say a few words on behalf of Mindray to Samantha. And once again, Samantha has been very kind. Of course, it'd be quite wrong of me not to thank Steve, who's not here, who's working hard. Steve, thanks very much indeed for the use of your mini bar. It's been very kind. And then we'll play out then with the video. So, Mindray, Cynthia.
Thank you, Dr. Young. Good evening, everyone. Firstly, I would like to thank Dr. Budram, and I would like to also to thank Dr. Young for imparting so much knowledge to everyone. And also, I would like to thank the Pelvic Floor Foundation, Ashley and Ashley and Karen. Thank you very much for a successful webinar. However, I just wanted to do a brief introduction of Mindray to those who don't know the brand. Mindray is a medical company that has been around for over 30 years, and we supply medical equipment in the hospital through our local distributor, RCA, and we have some artificial intelligence technology for women's health that we'd like to share with our audience. And one of them is the Smart Fetal Heart. I'm just going to do a brief introduction. Basically, with the Smart Fetal Heart, what you do, you acquire a 2D image, and then you press the M mode on the ultrasound control panel. Then the machine will automatically place the M mode sample line in the right position and will automatically measure the fetal heart rate for you. And the second one is in the 2D. You do the same, acquire the image. Then the machine will auto acquire the detection area and monitor the fetal heart rate in real time. So these are some of the IA technology that we have on our ultrasound machine. It definitely saves time for the doctors. So that is all from my side. Thank you.
Thank you very much indeed, Cynthia. Once again, Dr. Samantha Budram, safe home. We hope in the future, I really do mean this, that we can have you again. You're a wonderful speaker, and maybe even a debate with other experts in the field. And now we're going to play out with a Mindray video by Ash. Thanks again, Ash and Karen.
Thank you.
Safe home.
Thank you very much.